بره الميديكال انديكيشن بتاعه 30 في
الو. ايوه هيثم.
احنا سامعين حضرتك يا دكتور محمود، ممكن يكون.
فالمهم ان الاوزempic ده كان وانس ويكلي، بيتاخد مره واحده في الاسبوع سبكوتينيوس، وده كان بيستخدم المفروض لعلاج السكر. اتعمل منه الوجوفي ده بقى خد اف دي ابروفال كاوبيستي ميديكيشن في سنه 2021. بس مشكله الادويه دي برضه عشان تبقوا فاهمين ان هي فيري اكسبنسيف. يعني الوجوفي ده الجرعه الواحده منه ب $1000، فهي فيري اكسبنسيف. والمونجارو والوجوفي مش موجودين في مصر، والاوزempic نفسه حتى ما بقاش موجود. فهم برضو الميديكيشن دي مش متوفره في مصر. يعني الاوزempic كان موجود من فتره بس دلوقتي اختفى تماما. ساكسين موجود بس الساكسين مش ناجح قوي. هم طبعا افضلهم المونجارو والوجوفي يعني. بس دول دلوقتي فيهم مشكله ان هم فيري اكسبنسيف.
شاكر جدا لحضرتك يا بيه، شاكر جدا
العفو.
لحضرتك.
دكتور علاء جوين ده هو هيبتدي. اتفضل يا بيه.
الشير سكرين وصلت عندكم؟
موجوده
يا
يا
بيه،
باشا.
واضحة يا بيه، اتفضل.
بسم الله الرحمن الرحيم. أول حاجة كل سنة وانتم طيبين عشان النهاردة عيد الأم. ونتعشى من كلكم تكونوا افتكرتوا أمهاتكم وعيدتوا عليهم كويس. طبعا بنشكر الدكتور محي على مجهوده في تنظيم المحاضرات بتاعة البوست جراديويت، وإن شاء الله أكون يعني قضيته يوم كويس في البارياتريك سيرجري saving the worst for the last. موضوع complications طبعا موضوع ما هوش لطيف قوي، لكن we have to be ready for diagnosing and managing complications both for exams. It's an interesting topic to get questions and to be ready to answer them, and for the real life practice of that specialty. Like any other type of surgery, you have to be ready to diagnose and treat your procedure complications. هنعمل next slide ازاي؟ slide. Yeah. So as we all know from the day that morbid obesity is becoming a pandemic. Rich and poor countries now are suffering from the morbid obesity, becoming even more common than famine and underweight. Bariatric surgery offers only long-term weight loss in morbidly obese patients. It improves their life expectancy, and not only that, but also the quality of life during that time. And it does not only reduce weight, but also ameliorate many of the comorbidities or the complications of obesity. We know that you have many operations in bariatric surgery that are approved and very effective in producing a great weight loss. The Roux-en-Y gastric bypass, the one and a small gastric bypass used to be called the mini gastric bypass, the sleeve gastrectomy. These are the top three now in practice. The fourth one is upcoming, is the SADS. It's got approval from the IFSU and ASMBS, International Federation of Surgery of Obesity, as well as the American Society of Bariatric and Metabolic Surgeon, as an effective mainstream bariatric procedure. So we are going to talk about complications. First, complications related to the patient himself, and then complications related to the procedure. So as regards patients, we have many of our patients are young, fit, and healthy, but others are already suffering from the morbid obesity for a very long time, and that induced many of medical problems that the patient can be coming with already on board. Patient come with cardiac problem, with ischemic heart disease, with blocked coronaries, and having stents in them. Past history of deep venous thrombosis and pulmonary embolism is also much more common in the obese individuals compared to the normal population. Respiratory disease associated with morbid obesity like atelectasis, chest infection, sleep apnea, bronchial asthma, and even up to respiratory failure in some of our patients. The obese patients are more liable to have pancreatitis, and they can have complications from the pneumoperitoneum, and they can get complications from portal vein thrombosis after surgery, especially the sleeve operation. Procedure-related, the surgery itself can induce intraoperative complication as well as postoperative complication, which can be divided into early within the first 30 days or late complications. And this may invite revisions or reversals of the procedures, which can be considered also as part of managing complications of that surgery. The most famous restrictive operation, that is the way we used to divide bariatric procedures, restrictive, malabsorptive, and combined. More recently with the intervention of the different theories of these operations, how they work, the hormonal theory, the biliary change in the biliary circulation into the gut, as well as the change of the microbiota, are added mechanisms which make these operations work not only by the mechanical effect of restriction and malabsorption or bypassing segments, but also with other mechanisms. So we used to have the banding, which is becoming less and less practiced, replaced mainly by the sleeve gastrectomy, which also replaced the VBG with a vertical banded gastroplasty, which, as you all know now, is considered an obsolete procedure. The gastric patient again had its era in the early 2000s, and now it's again becoming less and less practiced. What's becoming more and more practiced now and is endoscopic bariatric surgery, which started as a management of complication and proceeded to interventional endoscopic procedures, starting with a balloon, now with gastric reductive and malabsorptive procedures through endoscopy, mimicking the laparoscopic procedures. The most famous malabsorptive operation, the biliopancreatic diversion, introduced in 1976 by Dr. Scopinaro from Italy. It was then changed to the duodenal switch or modified to the sinus stitch, which was introduced by Hess and S in the early 1980s. And there are some modifications of these procedures, most famously the SADI-S, single duodenal sleeve. The combined procedures are with limited degree of restriction and some malabsorption is Rowe-Nye gastric bypass and the one anesthesia gastric bypass, and their modifications according to pouch size, pouch banding, length of biliopancreatic limb, and length of the alimentary limb or the common channel. In 1995, the most famous paper of Dr. Boris, who noticed that the bariatric surgery have a very interesting metabolic effect, that patients can get improvement in their diabetes even before they lose weight, and this put the lights on the metabolic effect of bariatric surgery, and introduction of the metabolic surgery was mainly done by in the early 2000s, following the research by Dr. Francesco Rubino. He was originally in Chile and then moved to New York and eventually now into the UK as a surgeon for chair for surgery for diabetes. So he noticed that with the hormonal changes as well as the weight loss changes, the type 2 diabetes and the other elements of metabolic syndrome of hypertension, hyperlipidemia are all can be corrected and benefit from bariatric surgery. There are more metabolic procedures, ileal interpositions. These are mainly practiced in Brazil by Dr. De Paula and Santoro, which are the most famous in these interpositions and bipartitions as well. And more recently, Dr. Ricardo Cohen, the upcoming president of the IFSU and the president of the Brazilian Society at the moment. So if we're going to talk about the procedure-related complications, we have gastric banding, which was in the early 2000, 27% of the total of bariatric procedures, and dropped into in the early after 2010, the second decade of this century, to less than 6%. Intraoperatively, it's a quick procedure with minimal complications as bleeding and perforation, which are very rare, bleeding from short gastric or spleen or liver, and perforation at the dissection area of the lower esophagus or the upper stomach are very rare, and that's why this is considered a very safe procedure. But unfortunately, in post-operatively, on the long term, it has many complications like port site infection, band slippage, band migration or penetration inside the stomach, gastroesophageal reflux disease, progressive esophageal dilatation, and secondary achalasia. In spite of being the minimal restrictive procedure, it can end up with malnutrition if the band is too tight and the patient is not having proper nutrition. But what killed this procedure actually is the inadequate weight loss and the massive weight regain associated with the long-term use of this procedure, and that's why it's becoming less and less popular and less and less used as a single procedure. But it still has a place in adding it to other procedures, banding the sleeve or banding the bypass, to potentiate the efficacy of other operations or to be used for regain of weight after previous bariatric procedures to try to re-achieve another success by reducing weight. Gastric plication was introduced in early 2000 by Dr. Muhammad Talibur from Iran. His idea was to plicate the stomach in multiple layers of stitches to invaginate the greater curvature inside the lumen of the stomach to make it smaller and smaller. And his idea was using this sutures is much more economical and less expensive than using staplers. And he claimed at the beginning that this plication has less incidence of perforation or leakage from using staplers. But unfortunately, intraoperative bleeding and perforations happen with this procedure and postoperative leakage in the same percentage of stapled procedures. So this idea of being more safe disappeared, and it was associated with more incidence of vomiting and dysphagia and peritonitis. And again, the most important killer which stops this procedure or make it less popular is the long-term inadequate loss and weight regain, which is always the reason for abandoning procedures and becoming less popular, because this disease is a chronic relapsing disease, and the idea of minimizing the volume of the stomach to decrease weight as a single mechanism of weight loss usually does not stand the test of time, and eventually at least 40% of the patients on the long term will regain weight and need another procedure and make that procedure not popular. And this is what happened also with the VBG, been replaced now by the sleeve. It has very small instances of intraoperative bleeding and perforation like the band and the plication. Also, leakage and almost unheard of after the VBG, very, very rare, and the peritonitis. GERD and dysphagia is similar to the sleeve, but it has more late complication of stricture. The stricture usually occurs at the outlet of the pouch into the main stomach, which was measured or banded by a polyene mesh or sutures or a silicone band, and all this ended up into strictures in many, many cases. Stable line dehiscence with communication between the pouch and the greater stomach made this operation again fail on the long term, with the patient regaining a lot of his lost weight. Malnutrition in patients with strictured outlet and vomiting can have all the manifestations of malnutrition, like even more serious malabsorptive procedures. But again, the most important factor which makes this procedure obsolete is inadequate weight loss and weight regain on the long term, up to 40%. The sleeve still enjoys the fact that it is the most common bariatric procedure practiced over the last decade, crossing the 60% mark in any country at the moment, and it's rising. There's many reasons for its popularity. but it's still like any other procedure, have some incidence of complications. The intraoperative complication is bleeding from either short gastrics or solid organs, spleen or liver. Rarely perforation during dissection or dehiscence of the staple line, which is usually a malfunction of the stapler. Rarely the procedure can end up with a splenectomy if there is a bulb injury to the spleen or inadequately controlled splenic, very short gastric in the splenic hilum. Postoperative bleeding is the commonest procedure, the commonest complication after short-term complication after sleep. It's up to 3%. Leakage is usually around 1 or less than 1%. So that's why we need to be more careful about diagnosing patients with bleeding in the early postoperative period. The long staple line is in the sleeve operation is unmatched in any other operation almost. So with a very huge circulatory perfusion of the stomach, the staple line edge can bleed and can bleed profusely. Also can have bleeding rarely from short gastric or spleen or liver solid organs. Leakage is a dreaded complication in the sleeve, maybe even more difficult to treat than leakage from other bariatric procedures, because the sleeve has a difference, which is being a high pressure conduit with the pylorus closed at its end and the tube being narrow, and the pressure inside the tube is quite high, and that's why spontaneous closure of leakage from the sleeve is almost impossible, and you have to do interventional management to get this leak to be cured. That's contrary to a minor gastrogenostomy leak in one anastomosis gastric bypass or Roux-en-Y gastric bypass, which with a low pressure in the intestine, the leakage, if it's minor and well drained, may well even close spontaneously with time, NPO, IV fluids, and maybe some nutritional supplementation intravenously or oral through nasojejunal tube or a jejunostomy tube. With good drainage, this leak may even close spontaneously. Obstruction and stricture, they are uncommon. They are less than 0.5% of the sleeves, but they are again very, very serious complications if you have a very narrow area with a staple line coming very close to the incisura, and deceivingly this can be can happen still with the use of the bougie, and this actual stricture needs to be physically managed, and usually the dilatation is not enough, and you have to create a bypass between the upper segment obstructed stomach and jejunum, and create a bypass operation to solve the operation of stricture. This obstruction can be functional obstruction, not mechanical obstruction, with twist at this area, which again can happen immediately. Intraoperatively, you can see the sleeve turning anteriorly or turning posteriorly, depending on the mistake done by creating a short anterior, long posterior wall of the sleeve, or the reverse, a short posterior and long anterior, and this will create a twist in the sleeve, which becomes obstructed. This is for the short-term, immediate, early postoperative or intraoperative twist. Again, the twist can present after 1 month or 2 months after the surgery. The patient was drinking and started eating, and she was not vomiting, and suddenly everything becomes worse. And this is usually due to adhesions, which can be between the staple line and the liver anteriorly, if a denuded area created there, or posterior with the posterior abdominal wall, and this twist can progressively increase with the shortening of the fibrous tissue of the adhesion forming, and create a functional obstruction that needs management. These obstructions, being mechanical, functional and not mechanical, there's a minor chance of being possible to correct with putting a stent there for 4 weeks or so. But most of them still need a drainage or a procedure that bypass this area of twist or kink or stricture. The most important long-term complication of the sleep operation is the gastroesophageal reflux disease, which many people consider it the Achilles heel of the procedure, which will kill it in the future. It makes it less popular because of the, again, very high pressure zone inside the pouch of the sleeve and the massive rapid weight loss, which it happens after the surgery. There's sometimes a disruption of the anti-reflux mechanisms during the procedure itself with excessive dissection of the area of the hiatus, dividing the gastrophrenic membrane, the gastrophrenic ligaments, and this all can induce GERD, which can be either de novo when a patient was not complaining of GERD prior to that surgery, and this also can be associated, this de novo GERD, from sleeve migration, with again being cut into a narrow tube. The stomach can easily migrate through the hiatus compared to the full-size stomach, which have difficulty to go upwards. So interthoracic sleeve migration and de novo GERD are one of the important complications, and these two usually, if the degree of GERD is more severe than the second degree and not being well controlled with medication, will need an interventional surgery to correct it. The other type of GERD is patients already coming to you with GERD induced by his obesity, whether it's plus or minus associated with hiatus hernia, because the incidence of both GERD and hiatus hernia is higher in obese individuals compared to the normal population. And this puts us back to the fact that we have to make a very thorough pre-operative workup to diagnose these two conditions in obese individuals before offering them sleeve procedure. If you have a patient already coming to you with a third degree endoscopic grading of his GERD, even if he has no hiatus hernia associated, or a patient with a hiatus hernia bigger than 3 centimeters, many authorities find that these two situations are a frank contraindication for doing sleeve gastrectomy, and this patient needs to be advised to have a different procedure to correct his GERD and his hiatus hernia during the procedure, and creating a procedure which is not GERD inducing or interthoracic sleeve migrating, and this is definitely will be something different from the sleeve. Advocates or sleeves, or are strong advocates for sleeve, will try to do the sleeve for everyone. So they try to minimize the contraindication of GERD and hiatus hernia. So they would say hiatus hernia smaller than 3 centimeters or GERD degree with less esophagitis than second degree, mild degree of esophagitis, can be candidates for sleeve. But in these situations, you are really need to address the situation and not just create your normal everyday sleeve. In these patients, you are responsible now to thoroughly investigate the hiatus during surgery and preoperatively to find out how best is the way to correct this intraoperatively, whether by the new ways of not just adding 1 or 2 stitches to the crura, but also to try to minimize the postoperative GERD and the interthoracic sleeve migration, either by a cardiopexy. Cardiopexy has been really introduced and propagated by Brazilian surgeons like Santoro, or heel cardiopexy, the original previous heel to the arcuate ligament, or adding a fundoplication to the sleeve, which is really a very controversial procedure. It's been introduced by a French surgeon who's doing the fundoplication and then doing the sleeve afterwards. But as you all know, we have seen videos on the video channels of different gangrenous fundoplication associated with sleeve. And this is really a very sad complication, unnecessary one. And that's why the end-sleeve fundoplication sleeve is not popular. And there are other ways of trying again to do some fundoplication, the D-sleeve, the door stitch with the sleeve. And I think, in my opinion, these are all ways of trying to do the sleeve in spite of everything. It's easier to be a proper bariatric surgeon who have a variety of bariatric procedures under his belt. He can do it comfortably, successfully, so he can serve all his patients according to the patient's needs, not according to the patient's expertise. So surgeons expertise. So surgeons expert in doing sleeve and he doesn't know other procedures. He will try to do sleeve for everybody, adding N sleeve or D sleeve or cardiopexy, which is again an invitation for complications. It's better to avoid this and go for another procedure which will be successful in treating the morbid obesity as well as treating the GERD disease, like the Roux-en-Y gastric bypass, and minimizing the intrathoracic migration. Inadequate weight loss and weight regain is almost always there in all bariatric procedures except the big guns, the big procedures, the very aggressive procedures, the very malabsorbed procedures with short common channel. So, but all other procedures have an incidence of recurrence of obesity. They don't like to call it now recidivism or failure. It's better to call it recurrence of obesity. And this is again to avoid the blame towards the patient or blame towards the surgeon that the patient did not follow the proper guides after the surgery, so he gained weight, or the surgeon did not do the operation properly. But it's more to realize that it's a chronic relapsing disease, and like any other chronic relapsing disease, like cancer, like cardiac disease, you have many steps in the management, starting with medications and interventional radiology like stents and dilatation, balloon dilatation to the coronaries, and then surgery, endoscopically, surgery open, redo surgery, and the same happens with cancer. You treat the cancer recurs, you treat it again, you treat it with surgery, you treat it with medications, you treat it with irradiations. So it's a long-term fight that stays the whole life of the patients. Many of the lucky patients can get away with one single procedure and they become successful for the rest of their lives. Definitely they have done more effort than others, but for those who regain weight and become obese again, we don't have to blame them too much. We just have to accept the fact that this is a chronic recurrent disease, and if they are well indicated for a re-surgery, we have to offer them the ones we think it is going to be more successful than the ones they already have done. And that's why revisional surgery should add a new, and doing a sleeve and redoing the sleeve usually doesn't work. Removing a band and putting a band usually doesn't work. You have to introduce a new mechanism in your revisional surgery to achieve a better success. Endoscopic intervention started with the balloon. It is the safest, obviously, is no surgery, it's through the mouth. You put the balloon and you remove it after 6 months, and the more recent ones, you remove it after 1 year. But still have some drawbacks. The intolerance, the severe vomiting and pain, which can occur in the first few days, forces many of these patients, up to 1 to 2%, to remove the balloon immediately after insertion within the same week because of intolerance of the balloon. Balloon, if becomes deflated, it can migrate with an empty balloon down to through the pylorus and cause intestinal obstructions, the small intestine, whether at the ileocecal valve or anywhere else. It can cause peptic symptoms up to peptic ulceration, and we have seen even perforated ulcers or perforation over balloons for patients with severe symptoms, neglected for medications and neglected for recovering the balloon. They ended up with perforation. But again, the most important long-term problem with the balloon is being a temporary procedure that had to be removed. So usually the patients either inadequately lose weight or regain the weight, and many of the patients need other procedure in the future. Unless the patient BMI was very small from the beginning and the balloon was good enough to get him to a reasonable weight and he managed to sustain it. And this occurs in less than 50% of the patients with low BMI and balloon introduction. But the patients with high BMI with balloon introduction, the recurrence is 100%. So you shouldn't consider it as a treatment. You can only use it as a preliminary step to prepare high-risk patients to the definitive procedure you are going to do. So you can put the balloon for a few months, the patient loses some weight, his anesthesia risk becomes less, his fatty liver becomes smaller, and his obstructive sleep apnea improved. Then you can go for removing the balloon and doing the proper primary procedure you are going to do. So it's a stepwise procedure into high-risk patients. More recently, the endoscopic suturing becoming more and more with the advent of new technologies, more and more sound, and not just because the stitches, just being able to now to do full stitch, full thickness, full muscle stitches that can stand for as permanent stitches. And with this placating from the stomach from inside, it's a way to minimize its cavity size and lose weight. And to try to sell these patients, they call it endoscopic sleeve, because the sleeve is a popular operation. So you have the sleeve, you go home on the same day, it's done through the mouth. You don't have to worry about complications, which is not true, because endoscopic sleeves or plications have been a source of minor complication, rare complication, but serious complications. With these full thickness stitches, if the endoscope is ventured into the area of the fundus, you may get into short gastric or even the splenic bulb. So bleeding during the procedure or immediately after can be serious, and that's why the endoscopic sleeve or plication avoids plicating the area of the fundus, and they only placate the area of the body. You don't even placate the antrum again because it can cause mechanical obstruction. So you can understand that this procedure have a limitation because it leaves the antrum and it leaves the fundus as normal sized parts of the stomach, and that's a recipe for again weight regain. Because when we have a sleeve failure, we say that the fundus was not properly removed, that's why it's dilated, the patient's eating the fundus, or the antrum was too big and the resection started far away from the pylorus, so the antrum becoming the stomach reservoir and the patient regain weight. And this is in the endoscopic procedures, these two parts of the stomach are deliberately left in place without plication, the fundus and the antrum, and that's why the long-term perspective of this plication is going to be inadequate weight loss and weight regain. The bigger operations are the most malabsorptive ones. I call them the big guns. They have a very short command channel, and that's why the instance of weight loss is very good. The instance of weight regain or inadequate weight loss on the long term is very small. So these operations, by being the beginning, started in the 1970s, it has always been very, very small in percentage in practice. Less than 2% in any given year in any given country is only practiced 2%, in spite of the fact that it is the most successful operation as regards weight loss and weight and long-term avoidance of weight regain. And the unpopularity is only 2%, and usually second or third procedure, not a primary procedure, because of the fact that as they are the strongest and the most successful as regards weight loss, they also are the most dangerous as regards the incidence of complications, whether intraoperative, early postoperative, or long-term complications. That's why even many of these patients who had these operations and managed to safely go through the intraoperative and early postoperative period, they ended up with long-term postoperative complications that needed revision of these procedures to avoid long-term liver failure or kidney failures that can be fatal. So intraoperatively, these operations like any other interventional operative procedure on bariatric surgeries, incidence of bleeding and perforation, early postoperative bleeding, leakage, obstruction, intestinal obstruction, internal herniation are all more liable than any other procedure because of the multiplicity of the anastomosis done on the small bowel at different levels with multiple mesenteric windows. And this makes this procedure more liable to internal herniation and even without internal herniation, adhesive and sinus obstruction. And this can carry on with the patients for a long time, many decades after his original operation, he can present with this. The other nutritional problem is that these operations are, when they are done at the beginning of the piliopancreatic division of Scopinaro, the common channel was created as 50 centimeters on the ileocecal valve. With very short common channels, patient lost very good weight and improved his metabolic disease and comorbidities very nicely. But with this very short common channel, there is steatorrhea, flatulence, and severe malabsorption, protein allergy malabsorption were very serious complications. And again, having a big pouch that's anastomosis to the jejunum with a big anastomosis can create a cumbersome dumping, which can end into hypoglycemia and very difficult to treat. So when you move to the nutritional complications of any bariatric procedures, there are a long list. And we have to understand that these nutritional complications are not only associated with bypass procedures, bipartition procedures, bowel interposition procedures, but also with restrictive procedures which we consider small, like the sleeve or the band. Because if these procedures are associated with any mechanical problem creating difficulty for the patient to get solid food through, this patient is forced to eat fluid diet and semi-fluid diet, which can be very easily deficient in many of the elements, and it induces malnutrition. And actually, I have seen the Korsakoff syndrome, the B1 deficiency, with patients coming on wheelchairs after VBG, after gastric banding, and after sleep. Not as uncommon as you think. So you have to be aware, when the patient had a bariatric procedure, he should be followed up nutritionally for life. He's coming to us in spite of his obesity with nutritional deficiencies. We should really declare and define with our preoperative nutrition assessment. And then after that, we have to follow them for life, whatever the procedures they had, because they will have some deficiencies that needs treatment. And claiming that this procedure is a small procedure, a safe procedure, you don't have to have vitamins, you don't need to have blood tests, is really is not a safe practice and is not good for the reputation of the procedure or for the health of the patient. Bypassing the duodenum can greatly affect the absorption of iron, calcium, and many of the trace elements. Creating a Roux-en-Y gastric bypass separates the biliary secretions from the part of the small intestine, and this again disrupts the fat-soluble vitamin absorption. And these types of bypasses need the patient to have calcium, trace elements, iron, and fat-soluble vitamin replacements for life. If the patient is neglecting this, or if the patient is having it with not enough doses, this can be easily diagnosed during follow-up. That's why we have to do these regular tests every 3 months for the first year, and then every 6 months for the first 5 years, and once a year after that, once we know what are the enough supplements these patients need, and give it to the patient properly. Albumin protein malnutrition should not happen in bariatric surgery, but actually it does happen. Some of the mechanical problems that can be associated with improper measurement of the bowel limbs, because of the huge variation in the bowel length of small bowel. It starts from 4.5 centimeters up to 11 meters. So if you think when you bypass 2 meters in one anastomosis gastric bypass, and the patient have a high BMI, and you decided to make it 2.5 meters, and this patient have only 4.5 meters of small bowel, then you left him with a common channel of only 2 meters, and this patient can get into protein energy malnutrition and get into liver failure, kidney failure, and other problems. So the measurement of the part of the common channel is crucial if you are going to do a procedure with bypassing segments that's longer than 1.5 meters. If you are only bypassing 1.5 meters and this patient have a short bowel being measured of 4.5 meters, then you left this patient with a 3 meters common channel. That's usually very safe to avoid protein energy malnutrition. Liver and kidney functions should be followed up, as I said, because malnutrition can insult these organs. The gallstone formation. The story with the gallstone starts even before surgery. The incidence of gallstone formation in obese individuals is much more common than the regular population or normal weighted individuals. Up to 15% of our patients come to us already with gallbladders removed, or coming with gallbladders with stones in them, whether these gallbladder stones silent or symptomatic. So what we are going to do, if you have a patient coming already with gallbladder removed, then he solved his problem before coming. If the patient is coming with gallbladder in place, then you have one of 3 possibilities. Ultrasonographically normal gallbladder with no stones inside, or ultrasonography patient with gallstones inside the gallbladder, which are asymptomatic, or gallstones in the gallbladder, and when you discuss with the patient's symptoms, you will find that he's already had biliary dyspepsia for a while. So what the consensus being is now is that patient with normal gallbladder, no stones inside, asymptomatic, then you shouldn't go for removing the gallbladder during your primary bariatric procedure. And the choice is to give these patients medications, indoxycholic acid, 600 milligrams daily. During the duration, he's losing weight rapidly, first year usually, or up to a year and a half. This will minimize the chance of creating new gallstones during the rapid weight loss stage of his post-operative period by about 30%. It's worth giving this medication and leaving the gallbladder in place. Patient with symptomatic gallstones, it's quite clear that you should remove it immediately during the procedure or concomitantly with your procedures. Now we come to the difficult group. Patient with asymptomatic gallbladder stones discovered accidentally during preoperative preparation. Then if we go to the literature, we find that it's really divided. Some people would say you have to remove it because the incidence of early postoperative complication from the gallbladder stones are unacceptable, getting early postoperative biliary colic, obstructive jaundice. So if you're doing a procedure where your access by ERCP to the papilla and the lower end of the common bile duct is going to be disrupted by one anastomosis gastric bypass or roux gastric bypass or any of the bypass procedures that will not leave a pathway for the ERCP to reach the lower end of the common bile duct, then it's well better to remove even silent gallbladders with silent stones inside rather than having the much more difficult measures to treat calculable obstructive jaundice in a bypassed individual. If the patient is having a sleeve, the BMI is not too high, and the technicality of removing the gallbladder during the procedure is not too difficult, then removing an asymptomatic gallbladder with its stones is probably better. But if the patient BMI is so high and the technicality of doing the concomitant cholecystectomy with the sleeve is going to be dangerous or creating more complications. Because some complications showing that the incidence of complication from removing the gallbladder sometimes is more than the complication of the sleeve done at the same time. So if this patient situation is going to be a more risky situation, then you have to consider doing into stages, doing the sleeve first, and after the patient loses some weight and his BMI becomes less, then go for removing his gallbladder which is going to be technically easier after the weight loss. Necidiplastosis is a culmination of the management of the problem of hypoglycemia. Many of the bypass procedures are associated with dumping, and this dumping can persist into post-bypass hypoglycemia, which is different from the dumping that the patient gets hypoglycemia even without having a big sugar load. It becomes super active islet cells that produce large amounts of insulin in spite of minimal stimulation, and creating attacks of severe hypoglycemia, which can be disabling to the lifestyle of the patient. So with this hypoglycemia, the management of this complication is in 3 stages. The first stage is by nutritional support, teaching the patient how to eat solid food during carbs to minimize the rapid passage of food into the jejunum, to minimize the quick release of insulin. The second stage is by using medication. The carbose is a diabetes treatment, but in the case of hypoglycemia, it controls the degree of insulin secretion, minimize the attack of hypoglycemia. The third one is the operative treatment. And necidiplastosis means the hyperplasia affecting the islet cells across the board in the pancreas is not into one single insulin secreting tumor like insulinoma. So if you have a single point on MRI producing the insulin, then you can do limited resection, whether this being a Whipple procedure or a pancreatic tear resection, or even a part of the body that harbors this islet cell hyperactive spot. But if it's necidiplastosis affecting the whole population of the beta cells, total pancreatectomy have been tried. Unfortunately, it's not an easy operation, and living without a pancreas is also not easy, with huge swings in the glucose in the blood, and the medications are not good, and this idea has been abandoned. And the alternative surgical procedure is to reverse the bypass procedure and get the food to go back into the normal pathway, and this stands a good chance of curing the hypoglycemia. And you can do a test first by anastomosing your alimentary limb to the mother's stomach to make sure that the food will go into the normal pathway, and if this was successful, then you can go for the full revision after making sure that this or putting a gastrostomy tube and putting the food inside the gastrostomy, make sure that this cured the hypoglycemic attack. Then you go for the full revision, reversal of the procedure into normal anatomy to treat the hypoglycemia. Weight regain is also considered a complication of bariatric surgery, because the patient had his surgery to lose weight. If the patient regained weight, then it is an indication for treatment. Gastric bypass used to be the commonest procedures, dropped down to 27% now, whether it's being a row and Y or one against gastric bypass. It has the same intraoperative, very low incidence of bleeding and perforation. Post-operative, again, early bleeding, leakage, obstruction, intestinal obstruction, anastomotic obstruction, vomiting, acute gastric irritation of the mother's stomach if you have a kink at the jejunal anastomosis, intestinal obstruction due to adhesion, intestinal obstruction due to internal hernias, bile reflux in one anastomosis gastric bypass, stomal ulcer in both types of bypass, almost the same incidence, malnutrition, and gallstone formation. Gastric fistula, again, can present with gastroesophageal reflux disease or weight regain and inadequate weight loss. Complications of gastric bypass, sometimes weight regain needs revision to make it more stronger operation by minimizing size of pouch, size of anastomosis, change the length of the small bowel, or adding a band. Reversal in cases of hypoglycemia or severe malnutrition, reversal to normal anatomy usually is the best way to get away with these types of complication. Metabolic surgery in the future will be the aim in itself. It will replace most of the bariatric procedures, and it may induce new ideas and new thoughts in doing the surgery, minimizing the mechanical ideas of structuring of obstructing parts of the small bowel, bypassing parts, and rather to concentrate on the hormonal mechanism of the metabolic surgery rather than the weight loss mechanism. Leakage is a dreadful complication. We will run through it quickly. It can occur as a stable line anywhere. The common site is the gastroesophageal junction in the sleeve or the gastroesophageal anastomosis in the bypass. It has a small incidence, 1 to 2% in well-trained centers, a well-trained surgeon in large volume centers. It can occur intraoperatively for up to 40 days post-operative. The site, or as I said, also gastric junction staple line crossing, or associated with obstruction distally as the regional anastomosis in bypasses cases, or at the incisura in the sleeve. The best way of managing is leakage is to avoid it, or early diagnosis and manage it properly. How to avoid it? Technical intraoperative, use the proper stable heights, avoid overcrowding of tissues, try to use less number of cartridges is a disaster for recipe for disaster. Using buttress material to minimize bleeding, but it's not sure that it's going to minimize the leak. The technology of tri-stapler can produce better circulation to the staple line edge, but it's not again proven to minimize the leak. Avoid narrowing at the incisura angularis, which can create stricture or obstruction, which cause leaks up at the esophageal junction, the gastric junction. Avoid ischemia with excessive dissection at the cardiovascular junction, the least point of blood supply of the stomach that can create leak after 4 or 5 days. Avoid folding again inside the stapler, folding of tissues. Folded tissues will open into a hole. Use the proper size bougies, the small bougie associated with higher incidence of leakage 24 range, for example, compared to the 36 or 40. You can use intraoperative blue test or indocyanine green. Redo operation are associated with higher incidence of leakage due to the nature of devascularized tissues and fibrotic tissues and thickened tissues. The earliest sign of leakage is tachypnea, not dyspnea, before even tachycardia, with the phrenic collection. Pain on swallowing, left shoulder pain. If you left a drain, you can find what's the patient drinking come out from the drain. Delayed manifestation of tenderness or guarding in the obese patients. It's very, very late to find tenderness and guarding. Same applies for fever. Hypovolemia, oliguria, and hypotension is again very late presentation of septic patient. How to investigate it? Water soluble dye study, under screen, swallow and meal, whether it's routine or not. It's highly sensitive, but not the best. The most accurate is the CT with oral dye, and the CT with subtraction and 3D reconstruction is the most accurate way of diagnosing the leakage, site, size, and amount. Lab tests are not conclusive. Visceral count, CRP, and other manifestations are all manifestations of sepsis, which are really late manifestation, not early ones. So if you manage patients early, they have good general conditions, they are not septic, with well drainage, minor localized peritonitis. You can manage these patients with stents, with good drainage, they can heal nicely. Late patient with sepsis and peritonitis, you have to go in laparoscopically or open to take the patient out of the sepsis risk of multi-system organ failure, and then continue with good nutrition and good drainage through anastomosis or stent and wait for the healing to occur. I know that the 1 hour is very short for talking about all the complications of bariatric surgery, but I put many of the headlines and you can apply general surgery rules in managing these situations. I stress more on the specific complications of bariatric surgery, like the malnutrition, internal hernia, this leakage, and the hemorrhage. And I think I have to finish it off here, because this lecture, normally I give it in 2 hours. But with Ramadan, and what I'm giving is only 1 hour with some photos. These are the anastomotic ulcer. This is the stricture. Another stricture at the gastrogenostomy in a bypass. Another stricture in a SASI. Another stricture in a sleeve. A large ulcer in the stomach. Thank you, everybody.